tonight's presentations then are from the, as I keep saying, the PCRI conference last September. And Rick Brown would be giving this, although he's currently away, and so he coerced Jerry Hawley, our treasurer, into presenting his report, and it's an oral report, I guess. So, Jerry, with that introduction,
thank you.
Have at it.
I'm going to be at a bit of a disadvantage because I'm between glasses.
Was that wine or scotch?
Okay, thank you very much. Okay, this is from Rick Brown, and it just summarizes the conference briefly in order to give an idea of what it's like to anybody who might consider attending. The topics considered in the conference are extensive and range from holistic approaches to specific types of assessments and treatments. Because there is a multitude of events, one needs to pick and choose which topics are most important to them. Many sessions overlap or become full quite fast, so you might not fit into the room. When you register, you will get the full schedule and you can decide. There were also large exhibit halls with several sponsors and products to see and discuss with the attenders. Mark Moyad was the main facilitator and did a great job of clarifying the speakers' roles and bringing levity to the program. He's very well spoken and had lots of funny anecdotal stories. Please look at the DVD if you get a chance to obtain details of some of the content. To give you an idea, here are some of the topics covered. Newly diagnosed, active surveillance. They must have been copying us. Advanced disease, immune therapy, seed plant radiation, chemotherapy, and new investigational drugs. Relapse after local therapy, a men's group, a women's only group, sexual side effects, challenges of intimacy, different types of prostate MRI imaging, and new technologies. Many of the presentations were filled with medical terminology and jargon, which was intimidating to some, but it appeared many of the self-taught members of the audience were very conversant. Most of the sessions, however, were easily understood by any lay person. Also, there were lots of opportunities to ask questions, and the smaller breakout sessions were very accommodating for questions. Having said that, however, there were some time constraints, and you may have to wait to talk to the presenter afterwards. The video of the conference, I hope, should be a valuable tool to obtain details of any of the subject was not yet available at the time of this writing, and I am sure the prostate directors present will enlighten you as to how to view the contents. I would just like to add that throughout the conference there were recurring themes related to in the direction that better diagnosis was a key, followed by more of an emphasis on proactive surveillance based on the aggressiveness of the cancer. Also, some of the current diagnostic tools, such as multi-parametric MRI imaging, can give a better diagnosis and eliminate the needs for biopsies and the use of active surveillance. And the last comment, the PCRI has a great service called the Prostate Helpline, where patients and the curious can call and receive all sorts of help regarding this disease. You can also email help@pcri.org. Thank you. Sorry I couldn't be there. Rick Brown.
Thank you, Jerry. Next is our past president, Willem Smink, and Willem's got some slides, and if you'll give me the appropriate signal, I'll advance them. Willem, if you want a pointer? Or?
No, it's just going to be writing. There's no graphs. I saved all this stuff from the conference. I couldn't find it, so I'm down to words. And I had to retitle it because in a weak moment I call it metastatic, but what I really meant was castrate resistant, so it's a little different there. So what I'm going to talk about now over the next few minutes or a little while is why I went to the PCRI conference and what I expected to get out of it. So my history is I had my radical prostatectomy in December of 2007. And my radiation treatment in 2009. Obviously, my PSA had gone up in between. After the radiation treatment, it slowly climbed up to about 16, and so they decided to put me on androgen deprivation therapy back in October of 2013. And now I'm on my second cycle of ADT. I went through the first cycle, and I had a holiday for about a year and a half. And then I just come off a 9-month session of Eligard, and my PSA is at 0.4 right now, so I'm happy with that. So having that background information, I decided that the best thing for me to do was go to the PCRI conference and find out what would be a good, what my treatment options would be once I become castrate resistant. Castrate resistance, normally the average is it lasts about 2 or 3 years, and then you're into the next phase. So I'm at about 2.5 years now. So if I'm lucky, knock on wood, it'll last longer. But if I'm normal, then pretty soon I'll be doing something else. So the initial treatment, the one that's been around forever, is like for 3 or 4 decades, is things like Eligard or Leuprolide or orchiectomy. Thank you. Yes. I blame it on the drugs when I can't pronounce big words, but it's probably retirement because I don't have to think big words anymore. Anyways, both those options reduce androgen levels. They've been around forever, and they work. If they're going to work on you, they work well. And like I said, it usually only lasts 2 or 3 years, and then you got to get on to the next one. So, keeping in mind that when I went to this conference, I went to all the sessions that had to deal with options for me for where I was headed. So a lot of this stuff you've probably heard already, but I thought I'd give it a shot. So the first one that's really good is abiraterone. It's a new drug, and it lowers the androgen levels, and it does a much better job of lowering the androgen levels or testosterone levels than Eligard does. It's really a good drug. Then there's another one that they've developed in the last little while, which is called enzalutamide. And instead of stopping production of testosterone, it blocks where the testosterone is going to attach at the cancer point and stops it from working, right? So it inhibits the androgen receptors. These drugs are fairly new, like within the last 5 years. But just because they're there, that doesn't mean they're not working on them anymore. I mean, clinical research as to how best to apply these drugs is ongoing, because should they be used earlier than they do now? Should they be sequenced different? Should they be in combination with other drugs? Because all of this has a big effect on how the drugs work and how well they work and for how long they work. And it's still a wide open question as to what to do. The rapid, because those were developed so quickly, the rapid advancement from laboratory to the clinic shows what is possible when a clear understanding of the cancer biology is effectively applied, right? They went after the receptors and things like that, which they never did before. They always just went to cutting off the testosterone. Once you finish with all that, there's a chemotherapy option. Some of the chemotherapy options are Taxotere or docetaxel, same stuff. It's well established. It's been around forever. There's another one called Jeftana or cabazitaxel, which appears, they've described it as an improved Taxotere. I don't know how these drugs work, except they're a chemotherapy drug, so I'm assuming they're somehow interfering with the growth of the cancer. So when I was talking earlier about various combinations, chemotherapy has the same thing. They have Lupon Taxotere combinations, they have carboplatin Taxotere combinations. That particular combination is being used for lung cancer, but it's been investigated for prostate cancer as well, and it seems to be working quite well. Both have shown, like I said, good results. To me, immune therapy is the up and coming way to go. To me, it's got huge potential. All these other drugs the chemo and all these other drugs, they do things. They kill cells, they cut off testosterone, but this actually is personalized. Like the one drug is Provenge. That's it. Thank you. Hey, Provenge. That's one. It's a personalized treatment that works by programming a patient's own immune system to seek out cancer spreading in the body and attacks it as if it was a foreign body. It must be prepared specifically for each patient. It's really expensive, and they don't have all the kinks worked out of it yet. But I think given time, this kind of scenario is what's going to do it, right? Just because the shotgun approach isn't fine enough. You need the scalpel approach. There's another drug that they talked about, which was called Prostvac, and it's a phase 3 study. That one looks pretty good too. The study's secondary endpoint demonstrates that patients who received Prostvac had a median overall survival that was 8.5 months longer than the control group, a little over 2 years versus 16 months, and a 44% reduction in the risk of death. That's quite significant considering how early in the life of this whole immune therapy is working, right? And like I said, to me, immune therapy is the way to go. Anyways, next slide. Radiation. That one was approved in Canada about the time we were at the PCRI conference. It's called Sovigo. It's a radium-223. It's used for castration-resistant prostate cancer with the cancers that attack the bone, right? And no known visceral metastatic disease, so it hasn't attacked the soft tissue. It's only gone after the bone. They inject this stuff in there. It uses alpha radiation instead of beta radiation. It gloms onto where the most activity is, which is where the cancer is. Because it's alpha radiation, it only penetrates like 1, 2, 3 cells thick. So you can treat the cancer without damaging the tissue around it, which is a problem with a lot of radiation, right? So like beta radiation, you couldn't do it. But because it's so, well, I shouldn't say benign, but it's relatively soft-powered radiation. It binds with the bones at the site of the prostate cancer, and it's approved in Canada in 2015. And that's just kind of what I was going to say, was just what's all going on and what I saw was happening that would help my position. And then there was an interesting statement that was, there have been more drugs approved by the U.S. Food and Drug Administration for the treatment of castration-resistant prostate cancer in the past 5 years than in the prior 3 decades before that. Like, there is just a whole pile of research going on. I mean, what I just said doesn't even start to scratch the surface. It's ongoing everywhere. So I'm cautiously optimistic they'll find a cure before it's too late. Anyways, thank you very much.
Our next presenter is Bob Dixon. Bob is no stranger to our group, and he and Cheryl were going to do this. Cheryl took ill, and so Bob's going to fill in, I suspect, and give us both presentations. And he's going to talk a little bit about what his journey's been, and then proceed from there to the conference, I'm guessing.
That's pretty close to it. I'm going to be two of us tonight. Cheryl sends her regrets for not being able to be here, but she's down with a pretty bad cold. Anyway, my journey, to help set the stage where all of this comes from, starts with my forebears. Both my father and grandfather had prostate cancer. My grandfather was diagnosed with prostate cancer in his 80s. The doctor told my father, who had taken him in for the appointment first, and Dad told the doctor to not tell my grandfather because the news would kill him, not the disease. Anyway, they didn't. He lived on. He died in his late 90s. It's not clear to me whether he died of prostate cancer or died of something else. And at that age, it doesn't really matter. My father, though, had prostate issues in his 50s and procrastinated. He didn't get it looked after until finally my mother made him go in. But the diagnosis was too late. The cancer had progressed. He died at age 67 of prostate-related liver cancer 8 years after his diagnosis. This news wasn't lost on me. I have been monitoring my prostate. Sometimes I had to browbeat my doctor to do that since I've been in my 40s. Regular checkups through my 40s and 50s, monitoring my PSA and digital exam. I had my first 2 biopsies in the summer of 2012. The first was inconclusive, so I had another one done a month later. That first one, 2 of the 12 samples were abnormal, a Gleason 3+3. I was 55 years old at that time. A repeat biopsy a year later in 2013 had a similar result. I'm on active surveillance. My PSA trend is erratic to a maximum of 6.3. The latest test 2 months ago was 2.8. I have my next appointment in the summer, this coming summer. This is a chart that I developed because I hadn't been able to find one that talks about the entire prostate cancer journey. I developed it first from some stuff I saw from Dr. John Mulhall at the conference a year and a half ago, but I've updated it with new information. And we're going to tag through, and I'll show you how I use this. You see it starts at diagnosis, runs through until a terminal diagnosis. You can see across the top in blue the types of treatment that might come at the different stages. This is meant to be generalized, not specific to anything in particular. So pre-diagnosis is when you're getting your first PSA tests and your first digital exams, and you haven't been yet diagnosed with cancer. Though it's there in microscopic levels, which then grows, but stays within your organ, then it spreads, then metastasizes, the degree of cancer through your journey with prostate cancer. You get PSA tests done all along the way. Keep going. The imaging, whether it's ultrasound or MRI, that can assist your doctor in the interpretation of where your disease is at. And you get biopsies, sometimes many, sometimes few, all prior to your definitive treatment, so that your doctor can assess how your cancer is developing and moving along. My journey so far is way at the start. I intend it to stay there in the active surveillance stage. Here are my prostate metrics. The red dots, and I've only started my graph here in 2010 because they were all below 1 prior to 2010. But they started to rise in 2010, 2011, when I had my first biopsy, actually the 2 attempts to get one good sample. But since mid-2012, you can see that my PSA has generally been on a declining trend. There's a hole there in May of 2015, so what, 9 months ago, where my BPH acted up and I had a seizure in my prostate. I couldn't pee, so I got a catheter in. I happened to be in Honolulu at the time. So I came home, got that removed, and I seized up again 10 days later. Got a second catheter in, and about that time I was scheduled for a TERP. But I was also put on finasteride, and it worked. I didn't go for the surgery. I'm still peeing. I'm not winning any contests. But I didn't have the surgery, and I feel good for that. The finasteride has an effect on my PSA. It suppresses it more than it did before, so that last dot may not be on the same scale as all the others, but the trend is still on that downward slide, and I like that. Okay, next one. This is where Sherelle would step in. So I'm going to turn around. I don't look at all like that photo, but I'm going to read you her report. Good evening, everyone. My name is Sherelle Kopp. First, I would like to thank Prostaid Calgary for sponsoring me, as well as my partner, Bob Dixon, to attend the 2015 PCRI conference. Excuse me. The 2015 was the third conference I have attended. My personal journey has recently become more complex, as I am now charged with caring for an 84-year-old man with dementia and advanced prostate cancer, in addition to continuing to be supportive of my partner. My time at the conference was split between active surveillance updates and attempting to expand my knowledge of drug treatments. Although the 2015 conference did not disappoint, I found it to be slightly underwhelming this year. The trade show was very limited, with several vendors leaving early or simply not in attendance. Unfortunately, the women's group was not helpful or informative at the 2015 conference. The technical guest speakers were excellent, as always, and spoke of many advances in just 1 year, while emphasizing looking after yourself as best you can and being an avid participant in your own life. Active surveillance was accepted as a documented form of treatment at the 2014 conference. This trend continued at the 2015 conference, with active surveillance becoming a recommended treatment option for certain low-risk prostate cancers. There is talk that a Gleason 3+3 may not be considered cancer at all in the future. Since Bob's diagnosis in June 2012, the treatment choice of active surveillance has involved monitoring Bob's PSA supplemented by biopsies. There's been no change in this process. Overtreatment is still a major concern in the medical community for those with low-risk prostate cancer. At the 2015 conference, I once again concentrated on attending the sessions that were of particular relevance for the treatment option of active surveillance, nutrition and diet, and less invasive alternatives to biopsies as a monitoring option. The potential side effect of biopsies is an ongoing concern, and the effectiveness of less invasive technologies is improving. Bob will explore in more detail about these sessions. I guess I will. For the first time, I also attended sessions concerning advances in drug treatments. There's much excitement about new drug therapies and combination drug therapies. Details are discussed by Stuart and Willem. These drugs are expensive and often not available unless you are part of a clinical trial. The information is extensive and provided me with a basic foundation of knowledge to enable me to ask more questions of our healthcare providers in Canada. The PCRI conference once again reinforced the 9 objectives and provided opportunities in all areas, that being connecting, education, empowering, options, research, sharing, team, giving, and advocacy. Advances in research and the true belief by the physicians that prostate cancer will be one of the curable cancers is encouraging. Managing life and dealing with the side effects of all treatments was part of almost every session. These physicians see the whole person, not just the disease. Treatment options to deal with the concerns about incontinence and sexual performance and how this affects relationships were addressed. Bob and I are extremely fortunate that his shade of blue is sky, and I realize that a lot of you are not in the same situation. However, I can't stress enough for all of you to determine what is important for you in your journey, and if you cannot attend this conference, take a look at the videos. Take advantage of all of the resources that are available to you in an effort to improve your journey. Reach out to help others you may know to get them involved. Once again, the conference was not all business. There were excursions and opportunities for fun, enabling me to remember it is all part of life, and dealing with the roadblocks you encounter all depend on your own attitude and outlook. No physician or healthcare system has our answers. These must come from Bob and me through our journey together. After the conference, since we were in LA, Bob and I decided to continue the fun part, so we went to Palm Springs. Do not underestimate play. It is a very important part of life and relationships. I will attend the conference again, and I encourage each and every one of you to get involved. That's from Sherelle. Now Bob's back. I have two types of slides here. The ones that I call Bob's thoughts are my interpretations of what we heard, and the other part will be my takeaways, which is more of a reporting of what I was told, and often not put in total context, because each of the topics themselves might take me 15 minutes to explain. So first, some thoughts. Same as with both of the previous two conferences that I attended, there was an almost overwhelming amount of information available. You have to learn to take it in, triage it, focus on some stuff, and others you just say, I don't understand, or I haven't got the ability to understand yet. Sometimes a repetition helps. Triaging that information is important. What was mandatory to attend, what was optional, and what was unnecessary. And each of us would have a different definition of unnecessary or not. Sherelle and I developed our focus on active surveillance issues in line with my current cancer situation. Issues related to recurrent disease, heavy-duty drugs, repeat radiation are of lesser importance for us now. One, because I intend to be on active surveillance for a long time. Two, if those other issues become important, I will get to them then. And with the current rate of R&D, what's relevant now will have been supplanted by new learnings by then. Let me focus again. Hit that, advance the slide just once. I intend to be on active surveillance for a long time. Okay, next slide. Conference schedule. There were workshops on Friday, the main sessions on Saturday, and follow-up workshops on Sunday. Hit it once. I'm going to talk about new technologies later. I will speak to a few of the topics in the core of the conference, and I will pass over for now the workshop sessions, because you don't want to have me here till midnight. Some more of my thoughts. The presentations, there was a lot more information presented this past year than in prior conferences on the predictive ability of genetics analysis, or as some people call it, genomic profiling. I speak of systems like Prolaris, Oncotype DX, Decipher. They had some speakers tell us what all of it meant. Well beyond my capability of understanding how you sequence the genome and what's right and wrong. But there are some great potential advances coming that will help diagnose or assist your doctor in diagnosing what might be coming next. I also found a lot of the material was repetitive from previous conferences and or other sources. A good thing, because repetition improves the learning process. For me, those workshop sessions, either on the Friday afternoon before the main sessions or on the Sunday morning, were nearly as valuable as the mainstream sessions. because you get a different perspective maybe on the same topic. Some is repetitive, but it really helps. And incidentally, I captured more than 100 photo images of the slides. It's the first time I've done that, and it really helped my ability to come back and internalize with my written notes and prepare this session for you. Okay, now we're into my takeaways. So most of these will be in quotes, which means I'm repeating verbatim what I was told, not necessarily trying to explain it to you. I start with some miscellaneous items that don't refer directly to a particular topic. Those topics will come in a moment. One of them, I thought this was really insightful, is the second opinion of a pathologist is more important than the second opinion of a urologist. When you've got that pathology of your prostate and you're trying to decide what treatment should you have, the pathology really matters and is often not in agreement with the previous pathologist. After any treatment, the only way you will know if your cancer is controlled is by PSA measurement. And that goes with the last line there. PSA control is the only measure that should be used to compare primary treatments. The explanation for that is there's a lot of statistics out there that measure mortality. How many years have you lived beyond your treatment? Well, that depends on how old you were when you got the treatment, how sick you were when you got the treatment, and all the other potential morbidities. So he's saying the only way to measure and compare treatments is on PSA control. If you're looking at surgery, you're looking at radiation, you're looking at brachy, the right way to measure them is by PSA measurement. I'm sure there's others will have a different opinion. Then we go to drug therapies. Big names for big drugs, either on their own in combination, and Willem talked about that, so let's move on. I don't have anything to add to you for this one. We had a speaker there, Dr. Peter Grimm, talking about brachytherapy. And he made a very impassioned and presumably correct assertion that seed implant radiation for low-risk disease is better for cancer control than surgery and better than external beam radiation. Then he said the same thing for medium-risk disease and for high-risk disease. Very adamant. Now, he's a practitioner of brachytherapy, but very adamant that you have a higher cure rate using brachy than the other treatments. With regard to radiation, technique doesn't cure, it's dosage. And sometimes the higher the better. He had a discussion about temporary versus permanent seeds, and it was the first time I'd ever heard anybody refer to temporary seeds. I thought, oh, that's interesting. I doubt if I can get it in Alberta, though. But the takeaway, brachytherapy is not practiced as often anymore in the US and in Canada and maybe other places because it is not as profitable for the practitioners. The way it's set up with the insurance companies, just that's the way it is. Even though, as he says, it has a better outcome. Sexual function. And again, these are the quotes I took away. Understand what your treating physician means by erectile function recovery. It means very different things to different people. And he also had another interesting one. Sexual health, the #1 area of regret of patients after treatment. Something they maybe didn't think about enough, and they regretted the decision they'd made, or regretted their outcome for sure. ADT may work well at controlling your cancer, but is the most penis-threatening thing you can be exposed to. Think seriously in terms of survival benefit. Yeah. Penile injection therapy sounds awful, but the best drug therapy we have for erectile dysfunction, for those of you who care. And his takeaway for this was, let us not focus solely on adding years to life, but also pay attention to adding life to your years. Have a good quality of life. And if sex is part of that, you need to think about that. From active surveillance then, low-risk disease does not need treatment. Yeah, I really heard him talking to me. High-risk disease does need treatment. And so, for me personally, how do I assess the disease that I have? Is it low or is it high risk? A little bit about active surveillance for those who still think of it as watchful waiting. It maintains intent to cure if that is necessary. It is appropriate for men of all ages, and it does require reliable follow-up. It isn't just watch it and then go golfing for the next 3 years. One that I like, Gleason 3+3 rarely progresses. But in the pathological diagnosis, he was commenting that there's a higher prevalence now for pathologists to call it 3+4 rather than 10 years ago it might have been called 3+3. This isn't absolute, it's just gradational. And then risk assessment is the ultimate need. We need quality biopsies, imaging, whether it's MRI, multiparametric, or ultrasound, or any other kind of imaging, and genomics, or blood or urine markers. There's no magic bullet yet, but there's certainly progression in the way researchers are looking at that. And the acceptance of active surveillance as a valid treatment option is actually gaining in the real world, not just in our community. For MRI, and this was one thing that I'm really trying to understand, is how imaging can make a difference in my case. For patients with low volume, low grade disease, MRI provides two advantages. It gets to screening in those missed areas that biopsies can't get to, and it provides a baseline such that you can get comparison year after, or whenever, what repetition you get it. The resolution of MRI is superior, and contrast is also superior, to ultrasound and CT scans. However, MRI is not as effective in identifying low-grade cancer in patients that have been treated for BPH. It makes me stop and wonder, has my 2 catheters and now my drug treatment for BPH taken my ability to have MRIs away? I don't know that answer, but the question's there now. MRI by itself doesn't help much, because if you see a hot spot, you're still going to want to biopsy it to know whether it's cancerous or not. Very few people are going to want to say, oh, I've got a nice picture, I don't need to have any further tests. But MRI fusion biopsy can be helpful, but it has to be in the right hands. Not all the practitioners know what they're doing. A little bit of judgment on my part there. Up to 20% of men with a negative MRI will still have some cancer. MRIs still miss some cancers. However, the false negative rate is lower for MRI than it is for a systematic biopsy, because we know that biopsies sometimes miss them. And some potentially important cancers, and he said 15 to 30%, that's quite a few in my view, are MRI invisible. MRIs are still relatively expensive, and they need trained practitioners. More research. Now for an infomercial. In that new technology session we had on Friday afternoon, they had 4 speakers up there. 2 of them talked about genomic testing. I apologize, I don't remember what the 4th one talked about. But the first one talked about a system called SpaceOR. It's a hydrogel pill that is inserted. You have 2 pictures that the top image is a side view and the bottom view is a cross-section of the prostate and the rectum. This hydrogel pill gets inserted in between the prostate and the rectum prior to cancer radiation It does two things. It stabilizes the prostate better than if you didn't do it. More importantly, it separates them so you don't get the radiation hit on the rectum. The radiation has, just by definition, it stays farther away from the prostate. That hydrogel pill dissolves in weeks, I think he said. I don't know. You can't feel it. And it's safe. If you want more information, www.spaceor.com. And my summary. There's a massive amount of information at these conferences. I said sometimes daunting, I better say often daunting. But I certainly feel better about it. I'm more comfortable now with a better understanding of my disease and its probable progression routes. But I'm not done learning. And thank you very much to Prostaid Calgary for supporting and sponsoring our attendance at the conference. Thank you.
Thank you, Bob, and Cheryl, by extension. This last gentleman needs no introduction. He's our executive director on leave while he's going through some treatment himself, and I think that's what Stuart's going to talk to you about. I'll get this slide up. There we go.
Well, first of all, I'd like to thank everyone that has either spoken to me or emailed me to inquire about the status of my own treatment and what have you. You'll notice that I've lost my gray hair in certain spots, but I actually haven't had to shave my mustache for 5 years. That's interesting. It's just there. So it's not a fast-growing part of my body. And likewise, I have still eyelashes. That's the only hair in my body. There's a little peach fuzz here. It all came out within 2 weeks of the first infusion, and it was all over the shower in a matter of a day or 2 days. I feel great, and I'm having a very, very gratifying, satisfying experience with chemotherapy. Let me continue. Part of my history goes back to the initial diagnosis. I visited my family doctor in February, not 2017, 2007, how's that? So I guess I can still make mistakes when I type and when I read things. That's right, and I'm planning on coming back in 1 year. So I had an abnormal DRE. The prostate was as hard as a walnut, and you could feel as the doctor pushed around that he was moving the whole thing. It just was not a soft tissue. PSA 61.49. That's a hell of a way to present yourself, and I'll comment further about that a little later. So I was immediately referred to a rapid access clinic. Now I got the time and date right. That system works, and it had only been implemented for about 1 or 2 years at that point in time. But I quickly got in to see specialists at the rapid access clinic at their old location, and the urologist, he said, bend over. And before he was finished, he'd pushed that little walnut all over the place, and he said, you have prostate cancer. That's even without a biopsy. So you don't want a hard walnut for a prostate. We still had a prostate biopsy, and it was a Gleason 4 plus 4 equals 8, 5 of 10 cores, 15% of the gland. The gland volume was relatively normal, and the PSA density was 1.49. That's basically a ratio of the PSA divided by the gland volume, and somehow that's meaningful in the language of the urologists and what have you. I had a CT scan. We're fishing around to find out just how serious this is. and I had about 5 swollen lymph nodes. I had to pull out the dictionary to figure out all the words, and I'll come back to that a little bit later, that the histology report was saying and what the CT scan report was saying. But the good news for me is that the bone scan showed no active bone metastasis, and that is still my story today, 8 years later. No active bone metastasis. I just have lymph nodes, depending on the treatment and where I am in the cycle, they're either expanding or they're shrinking. They're very active, depending on how we insult the cancer itself. Part of this rapid access clinic is that I very quickly saw a urologist, and I also saw a radiation oncologist. I, in fact, didn't know who was taking care of me because I had too many people looking at me. And I asked, who's in charge here? And I finally figured out that I'm the one in charge. And you have to seek out information, and you do have to make some of your own decisions. But I did stand up to them and I said, you're the professionals, you tell me what your recommendation is. And that actually caused a group to come together to, of mixed disciplines to actually review my particular case. And then I got a recommendation that came forward. The diagnosis was high-risk disease. Here's the medical dictionary, retroperitoneal and left-sided pelvic lymphadenopathy or something. How's that? I didn't even know what that was. So I had to pull out Wikipedia and a few other good knowledgeable sources like Google to tell me what's going on. And that continues today. So what were the treatment options? I learned that surgery and radiation were not curative. And, you know, within the first 2 months, when somebody says, well, I could do something that would be palliative, that word palliative just didn't land right with me. But anyway, that's where the ouch came, and it was evident that I needed a medical oncology treatment strategy. The reason is, well, if you flip back, it's that, wherever it went, right there. I had a lymph node that was swollen, that was just in the region of my belly button, that was too close to intestines and too close to sensitive organs like kidneys and livers and things like that. And so it was outside the region of the normal pelvic area that would be treated if one was to take radiation. In terms of surgery, the disease had extended beyond had escaped the gland, and so the message was, you've got these cells circulating in your body, and so if we were to do a palliative treatment, you still would have these cells circulating in your body. So no cure. That became evident to me, and remember, I'm a chemist by first training, and chemistry has never failed me. I think I've said that before. So medical oncology was the treatment strategy of choice. That was actually an easy decision in the sense that I didn't have to worry about all of these various surgical options that people have. Didn't have to think through those. I didn't have to think through the radiation strategies and all of the issues of side effects. I just had to deal with drugs. Now remember, this is 8 years ago. Next slide. So I had essentially nodal disease. I had a CT scan later on in my journey, December 18, 2013, and the indicators that they were looking at, they could actually see some swollen lymph nodes. But earlier than this 2013, I had small golf balls where those lymph nodes were and are today. My prostate gland at that point in time was small, well-defined, size unchanged, and no evidence of expansion of the disease into the pelvic sidewall. So that's good news. At that time, disease status, the pathologist basically said, consider metastatic until proven otherwise. Next slide. Well, here's the history. I've been on drugs, and I'd first of all like to comment about this period of time here. I wasn't paying attention to what my body was telling me. I thought I was just getting older. But the body was telling me a few things. Maybe the erections weren't as firm. Maybe I didn't have the stamina that I had previously. Maybe I had to pee more frequently. It used to be I spent a lot of time driving between Cochrane and Edmonton. And about 2 years prior to this, I remember that I had to stop at Red Deer in order to go to the bathroom and get another coffee. I used to be able to sail straight through. I wasn't paying attention to a signal that was being given to me by my own body. A person just shouldn't normally arrive and present with a 61.49 PSA. I had PSA tests earlier when I bought critical illness insurance. But the issue there was that, and I'm sure many of you have had this with your own experience with doctors, is that they only report to you if there's something wrong. They don't report to you if there's something right, and they don't use it as an educational opportunity. So here I had the full 9 yards of assessment for my condition relative to purchasing critical illness insurance. My PSA had to be low at that time, but I was not following my own PSA. In fact, my doctor moved out of town, and I no longer was getting the phone call to book my appointments. I guess I'm supposed to take the initiative to book appointments. Anyway, that's the story there. Our organization does an awful lot of awareness to make sure that men in this region do not repeat that particular situation that I presented. So Eligard was the first drug, and really this was a positive story. What it said is that my disease is responsive to a reduction in testosterone. So the disease was of a certain type, which most people would have, that responds to along this androgen axis, I should say, to depletion in testosterone and also subsequently blockage of the androgen receptor. So that was good news. It didn't go down, my PSA didn't go down to less than 0.2, which is a target, which is an objective. So there was some residual level of cancer that was evident there. And we had a good ride for a couple of years, and then the level of the PSA began to increase. This scale is important. That is the PSA scale. So I became eligible for a research trial for the drug called Xtandi. I had seen that certain literature on Xtandi back about here in my own searching, but eventually I was able to actually get on that drug. And it was the luck of the draw, 50-50, get the drug, they don't get the drug, and then you either respond to the drug or you don't. So I've been lucky. I got the drug, and I responded within a matter of a week or so, and I knew things were getting better. Well, we continued on Xtandi for a good period of time, and then I became resistant to that particular drug too. And it was around here that we had this doubling time of 3 months or so, and I could easily have gone from 200 to 400 to straight through up to about there if I had not gone on chemotherapy. And the doc comes in and he says, well, Stuart, you know, I'm getting a little concerned. I said, yeah, I'm getting concerned as well. Let's get the party rolling. And so we went on to docetaxel plus prednisone every 3 weeks. And I'm at, this data is at the end of 6 cycles, and that's about an 80% reduction in PSA so far. And next slide. Another way to look at this data is to look at it from the point of view of the log scale. So this is 10 to the 1, 10 to the 10, 10 to 100, 10 to 1,000, or whatever. So what you see is a different, you visualize something very different, and a period of time when my disease is in remission, and then it just starts to trend straight up. And likewise, a period of time with Xtandi when it's in remission, and then trend straight up. And now I'm on this downtrend with docetaxel, which coincidentally 62.2 PSA is almost the same as what I arrived at my doctor with lower back pain 8 years ago. So I'm in a positive situation right now because I'm going down again. Next slide. Here's another way to look at the data. Take your data, folks, that you've got and convert it to a log 10 PSA. And this is really, really interesting because now you can use your Excel, and I've come in and I've plotted the docetaxel cycle, and I've got my log PSA, and this is just one heck of a curve. It's highly significant, R squared 0.997. For those who remember whatever statistics course you ever took or didn't take, it's highly significant. I'm at the 62.2. Believe it or not, if this projection continues after 10 cycles that I'm projected to be on, I will have a PSA of 10 to the 1. That's a PSA of 10. That's pretty stunning. But what if I continue for another 2 cycles? Now I'll be to 10 to the 0.5. Well, that's about 3.5 PSA. And what if I was to continue for another 2 cycles? Oh, right down to 0. I don't believe that. But that's what... And then I'm giving it to somebody else, eh? Anyway, my whole experience now is about whether I can tolerate these additional cycles. Next slide. What's on the horizon? Well, the current trend in PSA decline is my friend until the downtrend in the PSA decline is broken, resistance to docetaxel develops, or the toxicities to docetaxel become significant. I'm standing in front of you. I'm doing well. I have fatigue, but that's it. Well, I have some foul mouth, but that's it. I have some congestion in the nostrils, and sometimes when I blow my nose, my tear ducts throw out a squirt of something, and I've got the inside of my glasses that I have to wash. That's it. That's it. I do not have nausea. I do not have vomiting. I do not have diarrhea. I do not have constipation. Not bad. The other thing that I've learned, for those of you who are concerned about docetaxel, and I didn't know this, and I've had 20 buds from the Warriors group that have passed away over my 8-year cycle. They all had bone metastasis. I don't have bone metastasis. I don't have visceral metastasis. So I don't have it in the liver, don't have it in the kidney, as far as we know. What the nurses tell you, and you always talk to the nurses. These are the nurses right in the chemo clinic. And they say after 2 or 3 treatments, you're going to know, one, whether you're responding to the docetaxel with decreases in PSA, and two, whether you're going to be able to tolerate the drug for many, many more future cycles. So for those of you that have reservations about docetaxel, which I certainly had, the story's told in the first 2 cycles or 3 cycles. You can always stop. The problem is getting started. And some people, I even had a conversation in the last 2 days with somebody who's concerned about getting started with the docetaxel. Is it the right option for them? Well, if you're going to know within the first 2 or 3 cycles whether or not you're going to respond and whether you can tolerate, seems to me that's not a bad option. So the follow-up options for me is to keep the pressure on. And I haven't told my wife yet, but I might think about continuing for 1 or 2 more cycles. I don't know. I haven't mentioned it to my oncologist either. We'll let him come forward first of all, maybe. I have to closely follow the PSA doubling climb, and the radiographic progression, because this is where the story about the lymph nodes is told. If the PSA rises, I have the option of thinking about a re-challenge with docetaxel. And there's evidence in the literature that those who have nodal disease can actually respond quite well to a re-treatment. Not everybody, but you know, when the odds are more than 50%, that sounds not too bad. Sequence with new therapies. Bob and Willem spoke about sequencing in their own way. It could be combinations of docetaxel with something else, such as Lupron, and that's the most outstanding bit of new information in the last year. For someone who presents first time and is going on Lupron, the hormone treatment, there's now considerable interest to having those very same people go with docetaxel at the very same time. Hit it hard right at the outset. Would that have worked in my case? Possibly. I said to my oncologist last week, I said, I don't think I would have changed the path that I went on, even with the new information today, because I was able to delay the docetaxel without, I guess, too much risk, because I was lucky enough to get onto this Xtandi drug. We have several people here who are on Xtandi and have responded well to Xtandi, but it is no cure. There was mention of Jeftana, I've got that spelt wrong, cabazitaxel. This is actually possibly going to be a superior agent to docetaxel, and the reason is that research is developing in this area, is that it might prevent what is called cross-resistance. There is some cross-resistance between drugs, between the enzalutamide, the abiraterone, and the docetaxel, where you lose the effectiveness of the chemo treatment. The data that's coming out is suggesting that there is less cross-resistance with these prior treatments. My treatment being enzalutamide. There's others that have treatment with enzalutamide, or they've had treatment with abiraterone, or they've had both. And they may have built up a resistance in the case with docetaxel. In my case, I haven't, but there would be others that maybe have. So I'm going to keep active, and I'm going to enjoy life. Why not? That's what we're here for. Thanks very much, folks.
Thank you, Stuart. Spot on as always.
Can I ask one quick question?
Go ahead. No, just a minute. Chairman always runs the meeting. He has no idea. This is the end of our formal presentation, and we like to finish by 9, but we have time for questions from all our presenters. So, Louis, yes, you're on.
why the opening a cycle is so critical?
Sorry?
What, you know, you're talking about opening a cycle. The cycle is,
Yes?
why is so critical? What happened? Like, you know, like what happened? What stopped it from proceeding? Or it's like you're starting a cycle. You mentioned that,
Yes.
right? And then what sign? What's significant?
Oh, what are the signals?
Yeah.
On the very first treatment, you may find that you immediately start rejecting the intravenous treatment, like immediately. The nurses are paying a lot of attention in that first cycle. Secondly, it may take a little bit longer for you to have a negative reaction, and that can happen once you've left the clinic and you're at home. And so that's the importance of this first cycle. The second cycle, I guess, is whether you're going to have some GI problems that are, become significant. And there are men that we have in our Warriors group today that have had not my experience. They've had a particularly negative experience. And for them, moving to docetaxel is perhaps, aside from being one of the last choices, one of the last options, he may be able to tolerate that better than the docetaxel. But he's never going to know until he starts it. Any others? Yes?
What percentage of people who get prostate cancer would have the experience you had? Because yours isn't development.
Let me talk about it this way. When I searched novel disease, it's difficult to find good quality information about novel only disease. I do have a recent reference that was saying about 12% of men in the US will present with novel disease, and half of them would be recurrent from their primary therapy, and perhaps half, as myself, who just presented immediately with novel disease and no bone disease. As the disease continues, 85% of men will have bone disease, and perhaps half of those will also have visceral disease, soft tissue, i.e. the kidney, the liver, the bladder. So I'm a small percentage, I guess. It's a good one, but
Another question. That logarithm display you gave in the last graph, did you generate that yourself? Or
yes.
What did the doctors think about it when you presented it to them, or did you present it to them?
Oh, you like stats?
Did they adapt
They
that?
know that. They know that I've got scientific training, and that I'm a chemist by first training, and I can read half of that literature. The other half I can't read, so they know that. They become used to it.
One suggestion, you mentioned that you've got to go and get your PSA done. You test your PSA test
Yes.
after a while, and your doctor moved out of town, etc. So what I don't understand is that why do people not set up a standard order? So they go in every 6 months or whatever. That's what I do. So that way you don't forget. I mean, you have to be in charge of your own life, right? And second, when you have tests done, I suggest that you call up your doctor, set up an appointment, and find out what the results were. You don't have to ask for them to call you, because most likely they won't, and you're right about that. And thirdly,
I arrived when there was an excessive population and a few doctors in Calgary.
okay, thirdly, for people that have or have had prostate cancer, ask your doctor to get a bone scan, then you'll find out if the cancer has gone outside the prostate or not. I do all those things.
I do those because I was in the trial. I was getting an excess amount of treatments or blood draws. And then I also take acupuncture, so I'm full of holes. Yes,
When you talk about cycle, how long a time is that?
3 weeks.
3 weeks time, and you get chemo every 3 weeks?
Yeah. The way the cycle works, it's highly predictable in terms of what's happening today, what's going to happen tomorrow. I don't learn this because I've had to put up with it.
Mhm.
About day 10, this schnoz is going to just absolutely run for a day and a half. Guaranteed. I'm in about day 4, day 5. I'm going to have a real down day in a day or two, and I'll have no energy. I'll just probably take in a few movies on Netflix or whatever and just relax.
So you get sit by intravenous
Yes.
for 3 or 4
Right there.
3 or 4 hours?
1 hour.
1 hour?
Yeah.
Okay, thanks.
There's people there that are there for the whole day. They come in with their little ice box full of lunch and supper, and they're there for 8 hours of intravenous. This is just a 1 hour thing with docetaxel. Folks, like I say, thank you for all of your emails and your comments and support. It's been wonderful. And I am coming back, but I'm not coming back as executive director.
Oh, right?
We got an excellent one over there.
Good. Thank you, Stuart.
Thank you.
Thank you, Willem. Thank you, Bob.